Hi, good afternoon. My name is Adam Chapman, and on behalf of Fujifilm, I'd like to welcome you to our symposium today. Fujifilm is proud to be a platinum sponsor of Symposium Mammographicum, again for our virtual event in 2021. And we'd like to congratulate the organisation as it celebrates 40 years of supporting education, research, and innovation in mammography. This afternoon, we're very lucky to be joined by Dr. Laurie Fajardo, Professor of Radiology at the University of Utah. Dr. Fajardo has been an innovator in the development of stereotactic core breast biopsy, digital mammography, digital breast tomosynthesis, and breast biopsy markers. She has a particular interest in providing breast cancer screening to underserved and vulnerable populations and has advised national organizations, including the American College of Radiology and the Academy for Radiology Research. In addition, Dr. Fajardo has served on executive committees and in editorial positions for leading radiology journals in the USA. She has delivered over 200 lectures nationally and internationally and is the author of over 190 scientific papers. Today, Dr. Fajardo will be discussing the topic of breast density and breast cancer risk assessment and exploring how AI can add value to your decision making. She'll be joining us from the US to answer your questions after this presentation. Thank you.
Thank you. It's an honor to present at this symposium today. I'd like to thank the sponsors and the organizers who have gone the extra mile with the logistics that enable virtual presentations from around the world to be part of this meeting during these unusual times. This presentation will discuss breast density and the issues associated with assigning a breast cancer risk associated with a specific breast density. We'll look at qualitative and quantitative methods for assessing breast tissue density and discuss risk assessment, including how to incorporate comprehensive breast cancer risk assessment into your breast imaging practice. And finally, we'll discuss how artificial intelligence may impact your practice clinically in the near future.
Current status of assigning a woman's breast cancer risk due to her breast density makes it clear that discussions between a woman and her PCP may not be sufficient for providing guidance regarding personalized mammography and supplemental screening. And state-specific density notification laws complicate breast cancer screening discussions further because legislative requirements range from simply informing patients of their dense tissue to recommending additional screening and mandating insurance coverage. Fortunately, many radiologists express a willingness to assume the role of primary educator concerning breast cancer regimens to enable women to make educated discussions and decisions regarding the screening pathway that they are most comfortable with. So let's begin with a discussion about assigning breast cancer risk based on breast density. These are from the BI-RADS 5th edition, the density assignments that radiologists typically give to screening mammograms. The type A is fatty, type B, scattered fibroglandular tissue, type C, heterogeneous, type D is extreme density, and of course, type C is qualified as possibly obscuring detection of small masses, and type D qualified with lowering the sensitivity of mammography. So you may have noticed when the BI-RADS 5th edition came out that you might have changed your patient's density assignments based on the new criteria. More emphasis in the current edition of BI-RADS is given to the densest part in the breast tissue and not the percent of breast tissue, so that a mammogram should be classified according to the new guidelines as heterogeneous rather than scattered, even if the overall volume of the density would not typically place the mammogram in the heterogeneous category based on the percent of breast tissue. So this is a good example where There's heterogeneous breast tissue or even extreme breast tissue in the anterior part of this breast, but the remainder of the breast is fairly fatty. The density assignment to this mammogram has to be based on the densest area in the mammogram. Most women desire to know and ask how dense their breast tissue is. Nearly all radiology practices now provide this information to women in the letter with results that the woman receives following her screening mammogram. The primary motivation of breast density laws and patient notification is to alert women of the masking effect of dense breast tissue on their mammograms. Assessment of a woman's overall risk, however, must consider factors other than breast density, including family personal history, prior biopsy, BMI, age, to determine the need for additional imaging with a different technology. These are factors affecting breast density, and of all of these factors, only the decision to take hormone replacement therapy is a modifiable risk factor. The remainder are primarily hereditary. Having dense breasts poses three types of risk. First, the risk for breast cancer development, because dense breasts have a greater fibroglandular tissue element component that is capable of undergoing malignant transformation relative to breasts who have more fatty elements that do not undergo malignant transformation. Secondly, there is a risk for missed breast cancer on a mammogram because of masking effect, that is, covering the cancer with the dense breast tissue. Finally, a third risk is the risk for having a false positive recall due to overlapping or superimposition of normal tissue that creates pseudo-lesions that result in the radiologist calling the patient back for additional imaging. Regarding pseudo-lesions and false positives in dense breasts, these are the most common reason for recall. Recall asymmetries often turn out to be superimposed normal breast tissue, and these false positives are more common in women with dense breasts than they are in non-dense breasts. Tomosynthesis, or DBT, helps resolve pseudo-lesions by demonstrating that superimposed breast tissue is completely normal on screening mammograms so that recall is not necessary. Avoiding recalls for breast asymmetries is tomosynthesis's major contribution to reducing recall rates and screening mammography false positives. Cancers that arise in patients having dense breast tissue are more difficult for radiologists to detect. Further, more interval cancers, which are symptomatic cancers presenting between recommended rounds of screening, occur in dense breasts. Several reported studies have noted that up to 2/3 of interval cancers occur in dense breasts. The Breast Cancer Screening Consortium reports that interval breast cancers represent 15.7% of all cancers versus 4.5% of women with fatty breasts. Generally speaking, fatty and scattered fibroglandular density breasts comprise 50% of the population of breast tissue, and heterogeneous and extreme breast density comprise the other 50% of breast tissue. So when we ask the question, what is the risk from dense tissue? The answer is that it depends on the referent group. So one important question is, to what level should risk associated with denser breasts be compared? Do we compare the risk to the lowest category, the fatty breasted women who are only 10%, or do we compare dense breast tissue with an average density, the average of what would be found in the population? This is meaningful because if we use that 10% of fatty as the reference, this means that the other 90% of the population are going to be at increased risk, and there's no percent of the population that will actually have a lower risk. If we compare to the average density found in the population, some women will be designated as having a lower risk, some as average, and some as a higher risk. Depending on how you compare, you get different risks. So comparing the category C, heterogeneous dense group, with the fatty breast group, if this is our reference, we will find that this group has a 4 times risk for breast cancer. The extreme density patients will have a 6 times risk for breast cancer compared to this group, and the scattered fibroglandular tissue patients will have a 2 times risk. But if we use density B as an average risk for the population, the category C heterogeneous group has only a 1.2 times risk, and the very dense breast tissue, the category Ds, have a 2 times breast cancer risk. So we need to also remember that breast density is only one of several factors related to breast cancer risk. Breast density has to be considered along with other risk factors, such as age, sex, personal history, family history, especially first-degree relatives who are premenopausal, having breast or ovarian carcinoma, whether there has been atypia diagnosed on prior breast biopsies, and this would include atypical ductal hyperplasia, atypical lobular hyperplasia, and lobular carcinoma in situ. Extreme breast density as a sole risk factor does not necessarily put women into a high lifetime or 10-year risk for breast cancer, or stated differently, for the vast majority of women informed that they have dense breasts, breast density by itself has only a small impact on the overall risk. For instance, studies evaluating breast density and risk advise that risk calculating algorithms should also control for the BMI, or the body mass index, since postmenopausal obesity is another independent risk factor for breast cancer, but this is more often associated with non-dense breasts. Let's talk a little more about how we assess and designate breast density using the quantitative software assisted programs that are now available versus the way that we have done it for many years using the qualitative BI-RADS assessment. So these are 4 cases of breast tissue that would all be categorized as BI-RADS-C. And what we can see is that there's a very varied appearance in the density. It would be wonderful if all of our mammograms conformed to one of the 4 BI-RADS categories. But in fact, the variation within a single group, here we're seeing the C group, is pretty wide. Given these varied appearances, we should not be surprised that qualitative breast density assessment by radiologists has variation. In fact, studies have shown that breast density assigned to a particular mammogram may vary among different radiologists, or within that a same single radiologist shown the same mammogram just a few weeks apart. This slide shows results from a study that evaluated breast density assessment variability using the BI-RADS criteria. And they compared the 4th edition criteria to the 5th edition criteria among readers, 6 readers looking at 5 readers, looking at inter-reader variation and intra-reader variation. And the way that they did this study was to have these 5 readers assess the same 106 cases basically 4 times. They did it twice with the BI-RADS 4 assessments, separated by a period of time, and twice with the BI-RADS 5 assessment, the newer BI-RADS criteria. And this figure from the paper shows that 4 of the 5 radiologists read cases as denser. This is the proportion of cases assigned density. They read cases as denser using the newer 5th edition version, but there was some considerable inter-reader variation across this group. You can see that the percentage of cases rated as dense by either the 5th or the fourth over the same 106 cases was not the same among the radiologists. Further, intra-reader agreement shows variation as well. So reader 1 agrees with himself more often using 4th edition criteria than 5th edition criteria. In fact, that's true for 4. The intra-reader variation is less with 4th edition. One reader had better agreement with himself using the 5th edition. So this just illustrates that there's a lot of variation, and perhaps more qualitative measurements would be useful. So volumetric or quantitative determinations of breast density can be accomplished with software, and these software are in the clinics. Practices are beginning to use them now. How they're different from BI-RADS is that BI-RADS has this sort of stepwise A, B, C, D, but the software-based ones are able to make continuous models so that we can allow for the variations that occur, say, for instance, among all of these BI-RADS C breasts, so that the volumetric breast density determination on a quantitative basis can give variations within a single category. So for BI-RADS 3 visual category C, a software program can give a low C, a middle C, or a high C. And so we get these fine gradations of assigning density and the risk that is associated with density. This is an example of one of the available software that calculates what's called a validated breast density percent, or VDD. By qualitative BI-RADS criteria, this would be a C breast with heterogeneous density. And this particular software shows volumes of fibroglandular and total breast tissue calculated for each breast, right and left. And it calculates an average score. And the average score for the breast density in this patient is 8.2, which falls into a range. Their BI-RADS Cs go from 3 to 5. The 8.2 would fall in a mid-range. The overall volumetric assessment is a little bit higher, but still this is sort of the mid-range of a C. This is another continuous measurement that's available commercially. And here for this software, the dispersion of this scattered fibroglandular density breast results in a high B. It's almost a C. This graph shows relative breast risk assessment attributable to breast density for pre in the blue and post in the orange menopausal populations. There are 3 risk increases that are very common, and we show these here in decreasing order, where the highest risk increase would be having a BRCA1 or BRCA2 gene defect, which would increase your risk by 6 to 11 times. A family history, 1.5 up to 3 times risk, and then having dense rather than non-dense breasts would increase your risk 1.2 to 1.8. However, if we take these same risks and create a hierarchy according to the attributable fraction of the population that may be affected, we see that dense breast tissue, being relatively common in the population, becomes higher in the hierarchy as a risk factor, with BCRA, which is fairly uncommon, being somewhat lower on the hierarchy. So this is really another reason why we pay attention to breast density and why having more quantitative measures to more accurately calculate a woman's risk factor for breast cancer would be very helpful. Let's talk about how we can incorporate these tools into a comprehensive breast cancer risk assessment that you could use in your breast imaging practice. There are now a number of breast cancer risk assessment models available for calculating breast cancer risk. And 3 of them now incorporate mammographic breast density as a risk factor. One well-regarded risk calculation model is the Trayer-Cuzick breast cancer risk assessment model, and this has been incorporated by at least one manufacturer of software that assesses mammographic breast density so that you can have all of these tools available when you interpret screening mammograms to provide a more comprehensive evaluation of a patient's risk. And these models incorporate in risk factors such as these, advancing age, if the patient was older when she had her first child, if she was younger when she began menarche, or older when she underwent menopause, the use of hormone replacement therapy, number of increased breast biopsies, breast density, oral contraceptive agent use, radiation exposure, lower physical activity, obesity, and alcohol use. Breast quantitative density software programs and incorporate a risk assessment tool can enable us to do comprehensive risk screening if we want to initiate that in our screening clinics. So for example, by combining the Trayer-Cuzick risk assessment calculator with a qualitative breast density metric into a breast imaging reporting software, we could have these metrics in our software, in our patients' records, and it would help us make better decisions and have better conversations when patients come to talk with us about their breast density. This risk assessment calculator, which I'll go through over the next couple slides, has several data screens that require entry. And initially, it may seem like it's a lot of data to enter, and some clinics enter some, the primary data at the first screening visit and try to finish it up at the second screening visit if they don't feel they have enough time to spend with the patients gathering that information. Then after the information is entered, reviews and updates on subsequent screening visits help to keep it up to date. But the bottom line is having this risk assessment data can help radiologists have justification for recommending supplemental screening such as breast MR, contrast-enhanced digital mammography, or supplemental ultrasound, and for making referrals to high-risk clinics for genetic testing or genetic counseling. So this is the basic screen for the Trayer-Risk breast cancer assessment model. It gathers information on personal details, family history, use of hormone replacement therapy, and this is what the overall evaluation screen looks like. It's really not that big, but we'll go through the various components in a little more detail. So this is a typical personal information, the patient's age, when she experienced menarche, height and weight, what kind of measurements you use for height and weight. If the patient is nulliparous, this box will stay grayed out. So boxes only appear when there's information to be entered. So if the patient is still premenopausal, this box will stay grayed out. Information does not need to be entered. Prior biopsy data is also a part of this particular risk assessment. For hormone replacement therapy, it affects risk. We always ask patients if they're on hormone replacement therapy. They may tell us yes, they may tell us no, but the risk is dependent on the length of hormone use and how long ago it was used. So we ask them how long they've used it, if it was more than 5 years ago, less than 5 years ago. If they're a current user, the length that they've been using hormone replacement therapy can be entered, as well as the intended length that they plan to use hormone replacement therapy. For family history, beyond the patient, we gather information on the mother, the paternal grandmother, maternal grandmother, aunts, maternal aunts, and you can get information on lots of other secondary family members. So this is where, for initial screens, if a clinic feels strapped for time, they may only gather some of the family history, and then go back and get family history on cousins and nieces. And when you click these buttons, you'll have screens similar to these that will appear. So the primary information is ovarian cancer, breast cancer, and whether breast cancer was bilateral, and at what age each of these cancers developed. If the patient has had genetic testing, there is the opportunity to enter that as well. So this is just a sample of a completed patient risk assessment, and we can see her age, her menarche, and as all of these things are entered, she has a sister with breast, a sister with ovarian, and a paternal aunt that had breast cancer. As these are populated, a family tree appears. You can view the family history, and here we see the sister with ovarian, the sister with breast, the paternal aunt with breast, and here's the patient. After all this information is entered, including her breast density, we get a risk calculation that shows, relative to the population, what this particular patient's risk is. Also, for the patient versus the population, the percent probability that she does not carry the gene or that she does carry a gene is also calculated. So this is the report that you can generate. This is a print preview of a patient's report. And this will allow a radiologist to sit down with the patient, if so desired, after the conclusion of a comprehensive visit, discuss the patient's breast density, discuss the calculated risk from this risk assessment model. You can provide this report to the patient. You can provide a referral to genetic counseling or the high-risk clinic if this is warranted. And typically clinics will talk with their high-risk clinics or genetic counselors and say, at what risk level would you like me to refer a patient? So there are protocols for this. And this allows you to suggest appropriate supplemental screening and have documentation for getting insurance coverage of additional supplemental screening, because you will be able to say to the insurance company, this is the patient's risk and this is why this additional supplemental imaging is justified. Let's go to topic 3 for our lecture today, to talk about artificial intelligence and its many related applications to breast imaging. So some of the related applications with big data, data engineering, machine learning, and predictive analytics have entered medicine's magic bullet phase. Desperate for a solution to the never-ending challenges of healthcare cost, healthcare quality, healthcare equity, and healthcare access, there has been a steady stream of books, published papers, and corporate announcements that make it sound like healthcare is on the cusp of some type of artificial intelligence revolution, and one that's finally going to help us improve the quality of healthcare. The premise that more accurate and nuanced artificial intelligence-based predictions could be transformative in the domain of women's imaging seems quite plausible for improved interpretive accuracy, for improving workflow and efficiency, and for improving care and reducing costs. There are several considerations regarding improved interpretive accuracy that are germane to breast imaging practices. First, in the United States, conventional CAD has been traditionally used for most screening mammograms, but recent studies have shown that the use of CAD may not improve the diagnostic ability of radiologists. False positives distract the interpreting radiologist, leading to unnecessary recalls, workups, and biopsies. So artificial intelligence may offer better assistance with reviewing screening mammograms with fewer false positive flags than conventional computer-aided diagnosis. Secondly, artificial intelligence programs analyzing mammograms have shown performance equal to that of radiologists regarding the assignments of breast density. And that's why we've got programs out there now that radiologists are using. And these programs can very conveniently pre-populate our reports with the breast density information and appropriate recommendations that can be custom designed by the clinic. AI algorithms can enhance characteristics in mammograms and digital breast tomosynthesis image slices to make cancers more conspicuous so that we can more accurately detect. And this is already being done with image processing software that highlights microcalcifications, enhances architectural distortions, and leads to better detection of these particular abnormalities on screening mammograms. Now, in a recent DREAM challenge, which is a competition for artificial intelligence algorithms that was designed to detect breast cancer in a test set of mammograms that were given to each of the competitors, it was shown that the winning algorithm received an ROC curve of 0.87, and this is approaching the accuracy of experienced radiologists. Improved sensitivity in image analysis could strengthen clinical performance. However, the acceptance of artificial intelligence as a standalone or autonomous diagnoser of cancer in breast images will probably have a long way to go. The RSNA and the ACR are concerned about FDA approving artificial intelligence programs that will go beyond doing things that are aids or improve radiologist performance. They are very concerned that autonomous AI, which would essentially replace the radiologist, would not perform as well because there's much more cognitive input other than a detection on a mammogram that's required in the interpretation of medical imaging. However, on a recent survey of about 500 senior U.S. healthcare industry executives on AI, it was found that healthcare organizations are planning to invest an average of $32 million per organization on artificial intelligence implementation over the next 5 years. And this is a white paper that described that. But the primary reason cited was to improve workflow and efficiency in addition to reducing costs. A focus on workflow so that AI determined suspicious cases could be moved to the top of our list, or a triage to put our denser breast cases to the top of our list when we're more fresh in the morning, might very well be welcomed by radiologists. It's important that artificial intelligence not increase our reading time. Any review of artificial image analysis should be completely integrated into the routine image review process so that, for example, the AI is toggled on or off in some type of overlay, but it cannot require a lot of different clicks. It has to be well integrated and work well with the workflow that radiologists undergo in interpreting many screening mammograms in a day. AI could potentially reduce the time that it takes us to read. If AI could highlight all the important, not false positive findings in a DBT study and present that with a reduced number of slices, which perhaps might be individualized for an individual tomosynthesis study, this would be huge because it would reduce the amount of time that a radiologist has to spend searching the tomosynthesis study, and it would reduce the number of images that they would have to look at. Finally, there is perhaps the possibility that some non-cancer cases, fatty breasts, totally normals, could be read by the AI and a report generated for the radiologist in a situation where the radiologist would not necessarily have to go back and review it. I know this is controversial, but even if a small percent of these cases could be identified as negative with 100% certainty, a substantial amount of physician time could be directed to more complex cases, and this would really be analogous to what pathologists have already done for years regarding pap smears and flow cytometry. Beyond determining characteristics in a screening mammogram such as breast density and potential abnormal lesions, AI could incorporate predictive analytics to help us look at changes over time and assign a risk to a series of a patient's mammograms where there are changes in that data signaling increased risk or early malignant changes that are occult to the human eye. We know that cancers exist within the breast for 1 or 2 or possibly more negative mammograms before that cancer is conspicuous enough for us to see. So how would this be done? Well, we would identify cancers, many cancers, and those cases would be curated so that the type of cancer and the type of lesion that is manifested in those mammograms where the cancer is diagnosed would be identified as information and data that could be fed to an AI program. But in addition, the patient's 4 or 5 negative mammograms would also be pulled, and we would begin with an individual patient and move to a population of patients where we give the machine the first mammogram that's negative, the next mammogram that's negative, the next mammogram that's negative, any number of negative mammograms leading up to the positive mammogram that found the cancer. And what would be hoped would be that the deep learning and AI processes could begin to see over time what is changing in that particular patient that leads to a mammogram that has a cancer. And we'd have to give them a lot of negatives. They would need to have controls. But if there was something going on in a cancer patient several mammograms before her diagnosis that the machine can identify as risk seems to go up over normal studies. When the mammogram is still normal, we're not seeing anything, the algorithm could say, something's happening, this risk score is changing, this patient needs to have something else, a contrast-enhanced mammogram, an MRI, a supplemental ultrasound, and maybe AI could move the timeline back to where cancers can be diagnosed at an earlier stage, smaller size. So this risk for increasing change would prompt a score that would prompt a supplemental screening examination. So this is the obvious end goal that we'd like to get to, the ultimate goal. We'd like to improve care, and of course, we would like to reduce costs. So this means that the cost for AI interpretive programs has to be reasonable. It cannot be so high that it tilts the value equation for its use to where it's not adopted or accepted. Currently, a CAD is bundled, and the probability of getting a new code or a separate charge for artificial intelligence software would be challenging. So AI has to make itself useful by being reasonable cost and by saving time or doing other cost-saving things that justify its use in clinical practice. Reducing time for reading, improving efficiency and turnaround, incorporating more useful information such as breast density or cancer risk automatically into our reports that improves care and improves the value of our reports without necessarily requiring a lot of additional radiologist time. If AI could use predictive analytics to help us find cancers sooner, the reduced interval cancer rate might be reduced, along with increasing cancer detection and reduced false positives. Given that false positive mammograms are estimated to cost the healthcare system about $4 billion per year, tomosynthesis and its reduction of false positives, along with CAD, with less false positive flags, has the potential to lower overall cost of breast cancer screening. So in the end, models for quantifying AI cost-benefit ratio are going to be needed to demonstrate its efficacy and to encourage adoption and use. So just to summarize, artificial intelligence has some challenges to acceptance and adoption, but also has great potential. The biggest unknown is the AI box. There's this black box that does all these things, and radiologists, even data scientists, often don't understand how the algorithm works and what it is trained to exactly enhance in reconstructed images that could make my interpretations better. There are scientific concerns regarding how we train, how we validate, and how we test AI algorithms and the populations chosen, because one population may not be the same as another, and we want to have generalizability across all populations, races, ethnic groups that are represented in our practices. Some AI that's already approved by FDA works for 2D digital mammography, but not for tomo, or it works for this vendor, but it's not applicable to another. So there is a lot of variability into developing these algorithms that makes them generalizable across modalities and across vendors. It's very complicated, but it's very provocative, and it's moving at a rapid pace. So I expect in the next 3 to 5 years, we'll see some very interesting developments.
To summarize, breast density constitutes a risk factor for breast cancer that can be determined from mammography and tomosynthesis. It contributes to false positive recalls and false negative misses due to masking. Currently, there are qualitative and quantitative methods to measure and report breast density. Incorporating risk assessment tools such as Tyrer-Cuzick, along with breast density, provides a more comprehensive evaluation of breast cancer risk that may guide referrals for supplemental screening or genetic counseling. And finally, it is expected that AI will continue to mature into a technology that will prove extremely useful in breast imaging in the near future. This is a bibliography for the papers that I cited during this presentation, and I thank you for your attention.
Thank you, Dr. Fajardo, for such an insightful presentation, and welcome to Symposium Mammographicum.
Thank you. It was my pleasure. I'd also like to thank Fuji Medical for supporting this session.
I know we've got a few questions already come into the chat, so I'll just sort of move straight on to the first one that we had come in. So the first question that we had here was whether we should consider BI-RADS B as the average group, or the average should be calculated for every population in continuous measures such as VAS.
It's a very good question. I mean, I think right now, as a simple proxy, BI-RADS B is a reasonable approximation for using as the baseline referent group, rather than the patients who are completely fatty, which in our U.S. population is only about 10%. We need to get to some type of an average. Now, as all of these quantitative methods are being developed, companies have millions of mammographic informations, because typically the way that they perform the breast density calculations for you is in a cloud-based service. So mammograms de-identified go to the cloud. Their software works on the mammograms and sends it back to you with the scorecards and the percentages. And so it would be wonderful to go into these millions and millions and look at different geographic areas and then, really calculate what an average risk is, because you can see that depending on what you use your baseline normal risk, you can get a different risk for patients with dense breast tissue. And it's very confusing to patients. And it's also confusing to referring healthcare providers. What does this mean? And there's been research done by the BCSC. It's a US group called the Breast Cancer Screening Consortium, who has looked at dense breasts, and in particular, the BI-RADS-Cs and Ds. And what they have found is that not every BI-RADS-C patient is at risk for breast cancer. So clearly, beyond breast cancer, there's all these hereditary things, but they didn't even consider the hereditary things. There may be other things within the imaging that we don't yet understand. And for me, just reading mammograms every day, there are some BI-RADS-C mammograms that I read, and oh man, not so bad. They're pretty easy to read, and they're not complicated. But then there's other Cs that are very different in their pattern. The heterozygosity and the amount of complexity in that BI-RADS-C mammogram is different from another BI-RADS-C mammogram. And perhaps there is something in the data, which is called radiomics, that our eyes don't see, but smart computer programs could help us unravel to really see, are there identifiable risks just within the imaging data itself.
Cool. That's fantastic. Thank you. So just moving on to our sort of next question that came in, another interesting question here. So in the USA specifically, how do you adjust for the screening of ladies with dense breasts? So if you're currently screening at yearly intervals, do you add in any kind of DBT or MRI into their screening regime?
That's a very good question. And because, we're not organized at a national level like a lot of the countries in Europe are, it's sort of, we call it opportunistic screening rather than national screening. It is quite variable, and I think a lot of practices are confused about what to do. So we screen annually, and we do sort of divide our patient populations, and we know for the high-risk populations that have a greater than 25% lifetime risk that we are able to add MRI to screening those patients. And typically what those patients will do is alternate their mammogram with their MRI every 6 months if that works with their schedule. It seems to be a way to kind of spread out screening studies to make sure that you're doing something that helps you catch the interval cancers that the high-risk ladies might develop. Beyond that, people try to identify something called the intermediate risk. And is it 15 to 20%? Is it 10 to 20%? Is debatable. But with, some additional information to target, we can't do this. Half of our population is BI-RADS-Cs and BI-RADS-Ds. It's just not rational, nor is it cost effective to put a supplemental screening examination on 50% of the population. But if you could identify some others that are at this intermediate risk, a technology that I think is really promising and could be useful is the contrast enhanced digital mammogram. It's fairly simple to set up. We give iodine to patients for other studies, and of course we do need to think about that, but we also give gadolinium. But it's quick and it's pretty precise. It doesn't have a lot of false positives. It may have a few false negatives when you compare it directly with MRI, but for rural areas in the United States, where patients can't get access to an MRI, or even outside of the United States where there is no MRI, I think contrast enhanced digital mammography is really coming along and may be a great supplemental study. The other study that's used a lot in the US is the supplemental ultrasound. Some of it's automated, performed by machines, which have improved, but they have their own issues because, one size transducer doesn't fit every size of breast. And they are sort of have artifacts that come into the automated exams. And then we have the other side where the radiologist goes in and scans all the breasts. And, depending on breast size and the patient, it can consume a lot of radiologist time and ultrasound room time. And if you're thinking about adding this on to half of your population, and you think about how to control the workflow in your clinic, you can do many more screening mammograms per hour than you can supplemental screening ultrasounds, and it becomes a bottleneck. And many radiologists do not want to take the time to do these studies. Some do, mostly at academic places, and some are very well known for doing a good job, but this has not diffused uniformly in the United States to really the bread and butter community practice. So, we have a little way to go with that as well. So we're sort of all over the map. The other study is the abbreviated MRI, which we've done some trials for in the US. And I mean, what that offers is abbreviated studies that maybe perhaps take only 10 minutes to do. And they're good studies. They're very accurate. They pick up things. They still have the same occasional false positives that screening MRIs have for the high-risk patients. And there are pockets of places where they're done well and promoted well, particularly in Germany. But in the US, again, trying to come up with a way to do it that doesn't use a lot of resource and reduces cost to the healthcare system, whether it's insurance paying for it or whether it's your national healthcare program paying for it, it costs to have an MR in place. So you want to make sure that you're using these technologies to the best advantage of patients and, keeping the cost as low as possible to whoever it is that bears the ultimate payment for these technologies.
Absolutely, that's fantastic. Thank you. I think we just had some requests here. If you could possibly put your webcam on, Laurie. I'm not sure if
sure.
you are
Sorry.
able to. Just click the little thing. Oh, there we go. There you go. On screen. Fantastic. So I think we've just about got time for maybe just one more question. So just scrolling through here. So what's your view on the value of molecular breast imaging for screening of women with dense breast tissue?
Well, molecular breast imaging is another technology. It can be a little more complex, at least in the U.S. To do things with radiopharmaceuticals requires a different type of licensure and a different type of physician responsibility. So you have to manufacture the radiopharmaceuticals. It's not as easy as drawing up some gadolinium or drawing up some iodine. And it's just a little more complex. I mean, the dose has been reduced so that, the concern with dose at the beginning was very valid. The detectors are better. I'm not sure about the accuracy of biopsying additional things that MBI sees that mammography or ultrasound or MR doesn't see. But in the US, in the typical, a lot of mammography is not performed in the hospital setting. It's performed in clinic settings. And trying to set that up in the clinic setting, have, access to pharmaceutical, whether you purchase it and drive it in or manufacture it, the QA and QC that's involved with measuring the dose and making sure things are accurate makes it a little bit more of a barrier for radiologists to accept and use in their everyday practices. I would say right now it's limited to academic institutions and to a few like very, very good community practices like the Mayo Clinic's community practices. But,
Sure.
By and large, your average breast center is not doing it. And so when you have to make decisions, do I get MBI? Do I get I have a mammography machine here. What do I need to set up contrast enhanced digital mammography? Do I get another MR? Do I buy a whole breast screening ultrasound unit? People have to make decisions that fit with their practice patterns best.
Absolutely. That's fantastic. Thank you for your fantastic responses there, Dr. Fajardo, as well. And we really appreciate your time today, sort of going through your presentation and spending some time with you for your questions and answers. So thank you very much.
My pleasure.